Yeah.
Okay. So I'm Bill Mondrian. I'm a private practice doc in Edmond, Oklahoma. I've given this lecture multiple times in the past. I've given board review lectures on this topic and other GIs and ENT lectures and cardiovascular and some renal. I enjoy lecturing. This is the first time I've lectured in this class, so welcome to you guys. It's a pretty big deal that you guys are in this school. This is a great PA school. You were picked as the cream of the crop, and so there's a lot expected of you all. So Dan makes it very difficult. He makes it kind of an uphill climb from beginning to end. But when you all get out, you'll understand why it's done that way, and you all are doing very well. Most programs are not, I won't say difficult, but this in-depth. But you guys, when you come out, it's all about taking care of people. It's not about how well you do on any one test. It's not about how well you all do on boards, although that's very important. But it's about taking care of people, and remember that every day. That's what we're out here to do, and whether you're gonna be a cardiology PA or an ortho PA or whatever. Taking care of people is what's most important. And I've had 5 PAs work with me. Most of them have been pretty good. I've had 1 or 2 that really were not trained. They were not from here. They were from a different state. You know, it's just important. Really strive to be the best you can be. Ask questions of Dan and your faculty. They teach you all well, and when you all get out, you're very sought after, I'll tell you that, not just here in Oklahoma, but other places as well. So we'll move forward. This lecture, Gastroenterology, Series 1, because I have it set in Series 1, 2, 3 from proximal to distal through the GI tract. I'm going to be talking about the esophagus and the stomach today, which, you know, relatively boring topics, but there are some pretty common things. And remember, in medicine, what is common is common. That sounds foolish, but that is what you'll see the most often. That is what you'll be asked about on boards. That's what you'll be asked about on tests. And so you have to go over some of these common things that seem pretty straightforward, but that's what we're going to do today with a lot of this. Actual learning objectives. We're going to describe the etiology for disorders, the esophagus and stomach, obviously. You'll be able to recognize emergent and non-emergent topics. You'll be able to identify the appropriate lab and endoscopic diagnostic approaches. In other words, know what the problem is, what is the best test to order to really find out what the problem is, because that's a board question, what's the next best test? And then how do you treat it? And the idea being, we have lots of things out there. We have all sorts of toys, we have all sorts of machines, we have scanners, we can spend gazillions of dollars, and right now when dollars are being pinched down, 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 you need one best test or one best treatment to try and take care of a lot of this stuff, and not just shotgun it. That's one of the problems that a lot of us physicians and PAs do, is you say, if I order every test out there, one of those is gonna hit. I'm gonna treat it right, or I'll figure out what it is. Don't do that, you're smarter than that. Okay, so the esophagus, just representation of the esophagus in its position. Obviously it starts at the upper esophageal sphincter, moves down to the lower esophageal sphincter. It is a tubular, both smooth muscle and striated muscle structure. This slide and the next slide are mainly so you can see the orientation, and note the outer layer there is longitudinal. The muscles run up and down. At the very bottom, if I had a pointer, you can see that little lumen at the bottom, the inner muscles are circular. So you have both longitudinal and circular muscles. And what does that mean, and why is that important? Because the esophagus is a pretty impressive tube. It has the ability to contract and dilate, obviously, and it has the ability to squeeze linearly. So if you have a contraction and you squeeze linearly, that's called peristalsis. And all that is done automatically, or now that you're in PA school, it's autonomically. And so you swallow and you don't think a thing about it, but it moves down, your bolus moves down nice and smoothly, drops into the stomach, and nobody cares. But it's a pretty incredibly coordinated event to get that done. There's a lateral view of it where it runs in relation to the aortic arch. So it does take a little bit of a circuitous path. But notice again the outer longitudinal and the inner the inner circular layer. Now, not terribly important, but the upper 1/3 is striated, the lower 2/3 is smooth muscle mainly. And that's important because diseases that affect striated muscle, myasthenia gravis and the like, that affects the upper 1/3 of the esophagus. Smooth muscle diseases like scleroderma, that affects lower 2/3 of the esophagus. So you got to think disease processes. Where might I have dysphagia? Where might I have an esophageal motility disorder? Well, you think of the disease process. What does it affect? What type of muscle? We'll get a little bit into that. All right, so we're going topics now. Start with the topic, esophagitis. Not a very exciting topic, but it does occur. You see it pretty often. The idea is there are 2 real types of esophagitis. There's infectious esophagitis and there's inflammatory esophagitis. Infectious obviously has to do with infections. The most commonly occurring is Candida. These esophagitis or infections in the esophagus happen mainly in immunocompromised people. That is not just an HIV. Immunocompromisation is with medicines, prednisones, Medrol, all the steroids, all of the things we use for RA and the autoimmune disorders. They turn down your immune system. So you're now open for all sorts of infectious diseases body-wide. So if you look at what is most common, and by the way, you'll notice that certain names, certain diagnoses, and certain tests are in yellow. Those are ones that usually you see again, commonly we'll see again. But Candida is the most common infectious esophagitis, followed by herpes and cytomegalovirus. Those last two are common mainly because of HIV and immunocompromisation. So what are the clinical manifestations? Odonophagia, that's pain with swallowing. It's not inability to swallow, it's painful swallowing. If you've ever had strep throat or mono, you know what odonophagia is. You can have dysphagia, that's trouble swallowing. Not necessarily inability, but you have trouble, you choke, it sticks, you have problems with it, but it can give you dysphagia as well. These people have weight loss, they have upper GI bleeding on occasion. If you get any tissue and it becomes inflamed terribly, it can bleed. Know that esophageal candidiasis is also associated with oral candidiasis. That makes sense. Same thing with herpes. If you have herpes in your mouth, you get herpes in the esophagus. Happens mainly again in people who are immunocompromised. So here's oral candida. That is not strep. That is not strep. 100% of the time, I'll say 99.9% of the time, you go to an after-hours clinic, that person gets Cipro or some crazy antibiotic, which only makes that worse, and Cipro is the wrong antibiotic for strep, but that's not strep. Strep has an exudate, that's a superficial exudate that looks totally different. Okay, continuing on with esophagitis, what are we going to do about it? If it is infectious for Candida, you can use oral nystatin or clotrimazole. Those are pretty simple azole antifungals. They're cheap, they work well, no side effects. Unfortunately, in HIV, if people are immunocompromised by anything, they typically have some resistance. You don't get the help from the immune system because all of our antibiotics, all of our antifungals, all of our antivirals rely on a good immune system to work with them. So if they're immunocompromised, you end up going to oral or IV fluconazole or diflucan. Herpes esophagitis, oral IV acyclovir. There's several other choices below it. The choices below it are not generic. They cost a lot of money. They're great. They work well, but they cost a lot of money. You have to think about that when you're taking care of people. The CMV esophagitis really came back strong with HIV. You can use ganciclovir mainly. Foscarnet is almost never used. I've never seen it used, but that's just letting you know there's several options out there. Now, the other type, inflammatory esophagitis, non-infectious obviously, that mainly comes with radiation therapy. So people with lung cancer, sometimes with breast cancer, some skin cancers and melanoma, we use radiation along with chemotherapy. Adjuvant chemotherapy prior to this also worsens some of the radiation effect, but it makes a local inflammatory reaction of the esophagus, and it can be severe, it can be terrible, it can make you stop your radiation treatment for months. Chemotherapy, again, kind of adds the cytotoxic effect. People present with substernal chest pain, painful swallowing, and an inability to swallow as well. Coughing up blood is a common sign these people will present with. The treatment, nutritional supplements, some of these people you have to put a peg tube in. If they have inflammatory esophagitis from radiation, it takes weeks for that to heal. We can't go weeks without eating, obviously. So you have to put a peg tube or a gastric tube in these people and give them that way, but you have to get food, nutrition, and electrolytes. You have to delay the radiation. There's some topical suspensions like sucralfate. That's just for symptom. And then oral rehydration solutions via peg tube is commonly needed or are commonly needed. The key there is symptomatic treatment of time. Okay, so next topic, esophageal motility. Now, esophageal motility, as I kind of alluded to earlier, the ability to have normal peristalsis is a coordinated event. It all is under parasympathetic control, but it's autonomic control. There's a little bit of sympathetic control. But to understand what normal peristalsis is, you'll understand what happens with abnormal peristalsis or esophageal motility disorders, reflux, PUD, things like that. So we'll talk about those. But the idea is, obviously, it's a tubular smooth muscle structure like we talked about. We have longitudinal layer, we have the intercircular layer. Together, if they're driven well, you get a normal swallow, we don't think twice. Under vagal control, obviously. Okay, so that's a busy slide. You don't have to memorize that. You all have already been through that with anatomy and neuroanatomy. It's usually Dan's lecture, that slide. But note there, the 10th nerve, the vagal nerve, that nucleus sits low in the medulla. It's mainly a parasympathetically, it is a parasympathetic drive for the alimentary canal, the alimentary tract. It has wandering nerves, obviously, from the vagus, from the mouth all the way to the anus. And so, for this lecture, the idea is understand that it's all a balance. So many things in your body are a balance. We'll talk about several other things. But in all these lectures, for anything you can lecture about, always look for that balance, whether it's sympathetic or parasympathetic, or whether it's contractile or dilatory. But there's all these balances you need to really understand so that you understand when something goes awry. That just shows the innervation of the alimentary canal from the vagal nerve nucleus. Now the idea here is there are disease disorders that can degenerate your vagal nerve nucleus. There are disease disorders that can degenerate the vagal nerve fibers or the ganglion cells in the wall of the organs. Any one of those give you a dysfunction of your vagal tone. Normal peristalsis, that's actually almost nutcracker, but that right there shows you the temporal relationship across the bottom is time, across the left side of that slide are different levels down your esophagus. So you can see that there is a contraction that moves temporally down the esophagus, and that is what normal peristalsis is. It's just an illustration. This is better, that's more normal. The amplitude, notice, we'll get back to this, between 60 to 80, sometimes 100 millimeters of mercury. That's all the harder that the esophagus needs to squeeze. And so you guys understand, any viscous structure in the body, whether it's the esophagus, whether it's the colon, whether it is your ureter, any tubular structure, they don't feel pain. You can cut them all day long and you don't feel anything. What they feel is dilation and contraction. So as long as there's contraction that is normal amplitude in any of these structures, you don't feel it. But if you over-contract, if you hyper-contract, or cramp, some people call it, or you over-dilate, it is terrible pain. If you've ever had a kidney stone, then you know what I'm talking about dilation and hypercontractility. So as long as you have a normal peristaltic movement temporally down the esophagus and across time and across the bottom, you see where the lower esophageal sphincter opens up, your bolus drops into your stomach, you don't know the difference and you go on about your way. So if we have any disorder of that balance, we get into our motor disorders of the esophagus or esophageal motility disorders. They use that term, esophageal motility disorder, on your boards. So that's what we're talking about. In general, they present with chest pain, dysphagia, or both. Dysphasias with solids and or liquids. Usually it starts with solids and through time as whatever you have worsens, liquids become a problem. You have oropharyngeal and you have the esophageal body type of dysphagia, and the difference is oropharyngeal dysphagia is more of a coordinated or loss of coordination of movement of a bolus of food or liquid from the front of the mouth into the esophagus. The epiglottis has got to move, you've got to put things down the esophagus, and that's a really coordinated event. There are all sorts of neuromuscular disorders. MS is one of them that ruins this coordinated event, so people are not able to swallow. They have the ability for their esophagus to move, but they can't coordinate getting the food back there. Now, if we go to the body dysfunctions, those are the ones that mainly have test questions on them. But those are the esophageal motility disorders that we'll get into a little bit. They're the most common esophageal motility disorder. Etiology is commonly unknown. Achalasia is the big one. That's the one that I bet 6 or 8 people in this room have, and you may not know that you have it. For those of us that have ever had it, some people swallow, they know their food gets stuck, and they cannot get it to go down. It feels like it hits a locked wall, and sometimes people leave the table and have to throw it up and think, oh golly, I just had a spasm. And that's commonly achalasia, but it's incredibly common. You have disease processes or infections that can cause it. Chagas disease is one that affects the motor neurons and the ganglions in the wall of the esophagus, and it just stops the esophageal motility that's normal, and you get food that's stuck in the esophagus. Bless you. The idea of achalasia, this is the whole key to this. Achalasia is characterized by a dilated body of your esophagus, and the lower esophageal sphincter, the door at the bottom, is slammed shut and won't relax. And in understanding that, your parasympathetic tone for the esophagus, in the body of the esophagus, that is contractile. If you have good parasympathetic tone, you contract your esophagus and it has tone. If you lose that, obviously it dilates. The same parasympathetic tone, the fibers that reach the lower esophageal sphincter, they are dilatory. They relax the lower esophageal sphincter. So if you lose vagal tone, you end up dilating the body and not being able to open up the lower esophageal sphincter. And so that's what this slide's about. You can have it with degeneration of the motor nucleus itself, the fibers, or the ganglia of the wall. But they do opposite things in the body and the LES. That is a barium swallow of achalasia. And it's incredibly common. The barium is just hanging in that dilated body of the esophagus, and the door won't open. They call that a bird beak appearance on barium swallow. You only get to this point of doing studies on it when people say, I can't swallow, I'm losing weight. Everything I swallow gets stuck, I don't know what I'm going to do about this. Now, that is as opposed to diffuse esophageal spasm. That is exactly what it sounds like. It's a diffuse esophageal spasm. The key to know here is it is aperistaltic. It's diffuse. There's no temporal relationship from proximal to distal. The trigger is usually a swallow. A larger bolus triggers this more often than a small bolus. So people that eat quickly, people that are type A, people that run into a restaurant, order something, jam it down, they typically do this. They're the ones that lean over the table, they think they're having a heart attack, they actually have a vagal attack, a vasovagal attack. Sometimes they'll pass out, they'll get pale, they'll get bradycardic, they'll sweat, and some of you all probably seen friends or know somebody that's done it. But you get a diffuse spasm of your esophagus and food goes nowhere. Treatment, supportive, empiric, you can use smooth muscle relaxants, but you don't need that. Just slow down your eating. Some people have a predisposition to it. Those are people that live in high adrenaline states, again, the type A folks. So that is a diffuse esophageal spasm. And notice that in the manometry graphs there, there's no peristaltic movement. The spasms are one on top of each other, the contractions are one on top of each other, so food is not going to move. High amplitude occasional contractions, remember what I said, the amplitude of the contraction with viscous structure gives you pain, so that is the pain in their chest. That is a barium swallow of diffuse esophageal spasm. You can tell that's not going to move food anywhere. In fact, food's probably going to go backwards in that case. Now, nutcracker esophagus. They like this on tests, they like this on boards. It is a real thing, it's common, so you'll understand it. And it's all about the history. When you talk to these people about, gosh, I can't eat, gosh, I can't swallow, you got to dig into the history. Well, when you do swallow, what happens? Do you ever have to regurgitate? That tells you if they're having peristalsis or not. So that gets into the history. But nutcracker esophagus is a functional peristaltic esophageal motility disorder. Meaning, you do get peristalsis, you don't regurgitate commonly, food does move down into the stomach, but the entire definition is based on the ultra-high amplitude contractions. So this is a pain syndrome. These people say, gosh, now I swallow even a little bit, and I can tell you exactly where it is, all the way down in my chest till it drops out, and then they lean back in their chair and say, I'm done, I'm not worn out, that hurts so bad. These people really have problems, these are terribly painful. So chest pain, no dysphagia is the key there. Treatment, muscle relaxants, nitrates, you don't need to go to that. It's just reassurance and biofeedback. For these people, again, if you can calm them down, beta blockers in some cases, getting these type A people to relax and give them essentially an anti-adrenaline calms them down quite a bit. That's nutcracker esophagus. That is peristaltic, but notice the amplitude. I said you want 40 to 60 millimeters of mercury when the esophagus contracts. These people have 200 plus. That is painful. These people, that person probably would pass out when they swallow. Okay, next topic, off the motility disorders, Mallory-Weiss tear. This is something that's relatively common. You will see it in practice. If you do general practice, you'll see it if you do GI. Incidence and epidemiology are all over the scale, so I didn't put too much of that. But in general, it's a major cause of upper GI bleeding. It occurs in the distal esophagus. It occurs right at the esophageal gastric junction. This is where people that have vomiting disorders, people that drink a lot of alcohol, people that overeat, some people with gastroenteric infections, when they have violent, forceful vomiting, they stretch the JEG, the junction there, too quickly, and they tear it. So these people do bleed. They don't bleed profusely unless you have esophageal varices, which we'll show in a minute, but they do bleed. And so if you talk to somebody and they say, gosh, I had gastroenteritis, I vomited for a couple hours, but then I saw blood in my vomitus. Well, they're going to ER because they know they're dying. You don't necessarily have to do that, but just know you don't need to panic either. You need to know why they're bleeding, but it's commonly a Mallory-Weiss tear. So how do you diagnose this? Endoscopy. It's kind of an obvious statement, but endoscopy or direct visualization of the mucosa of the esophagus tells you they have small linear tears through the ruga right at the distal esophagus. That's what it looks like. Now, you can tear all the way through. That's different, that's called a Borhaus tear. But a Mallory Weiss tear, you're tearing the mucosa because of the forceful vomiting, then it causes upper GI bleeding. The worst risk is if these people are alcoholics. You have alcoholics that are chronically vomiting, they will eventually tear through the esophageal varices, or varix, and they will bleed out through the mouth. It's terrible. So what's the treatment? The key is try and stop their vomiting, put them on Zofran, put them on Phenergan, put them on something. If they won't stop bleeding, if they're on aspirin therapy, they're on some other antiplatelet therapy, you can go down there with the EGD scope and you can do light injections of epinephrine right over and around that area that's torn, and it'll stop the bleeding, arterial constriction. The key there, the most common complication, by the way, was rebleeding. All right, so moving down, obviously we're moving proximal to distal. We're going to get into reflux disease. Reflux disease obviously is common. Many of us in here have reflux disease. It depends on what we eat, what we drink, our weight, whether we have asthma or COPD, those kinds of things. But it is common. They love it on tests. They love it on boards. So if you just understand the basics of it, you can answer about any questions about GERD. Epidemiology, 10 to 25% prevalence in the Western world per year. That's not, for your lifetime. That's per year. People have the symptoms. Keep in mind it's a symptomatic, it's a history type question. Have you ever had heartburn? Have you ever had regurgitation? Have you ever had problems swallowing? Well, who hasn't? But 10 to 25% prevalence, point down slide, it's common. What's common is common. So this is where we start making sense of what's normal. This is normal peristalsis. We see it again. Upper esophageal sphincter relaxes, you get temporal squeeze, 60 to 80 millimeters of mercury that moves temporally forward and down the esophagus. Lower esophageal sphincter opens up, the bottom graft lets the bolus drop in. That's fine. As long as that lower esophageal sphincter, what we're talking about now is that bottom part of the graft. Notice the resting tone, 40 millimeters of mercury, not important to know, but the key is you have a resting tone. So your door stays shut. Once your bolus drops into the stomach, your stomach ruminates for 1 to 3 hours, mixes that food up, and as long as the door at the top of the stomach, the bottom of the esophagus is closed, nothing squirts back out. Anything that gives you a dysfunction of that lower esophageal resting tone gives you GERD. So there's two different ways to acquire a weak lower esophageal sphincter. Again, across the bottom graph, notice that is a chronically weak lower esophageal sphincter. There are some neuromuscular disorders. There are some infections, and there are a ton of medicines that cause this. Foods do it as well. Peppermint, chocolates, they can also cause a chronic lower esophageal sphincter weakness. If you just have them on occasion, then it will be a transient weakness. Medicines are famous. Blood pressure medicines do this. Smooth muscle relaxants. Calcium channel blockers, remember what calcium channels do? They make muscles relax. So they drop our blood pressure by arterial dilation. Not important here, but the idea is you don't get to pick what muscles relax. So if you also relax the lower esophageal sphincter, when your stomach ruminates, you get reflux. Now the point of this is chronic weakness versus transient weakness. Two different types. This is episodic. This is with meals. This is alcohol. This is peppermint. This is chocolate. This is using your inhaler. So you get a transient drop in lower esophageal sphincter tone you see across the bottom. And so which one of those two is more common? It is clearly the transient relaxation. That's been on boards once. I throw that up there. Idea is transient is far more common than chronically weak lower esophageal sphincter. So what are we going to do about this GERD? And it's obvious, straightforward, but start on the left. We can use antacids and anginic acid. We can use sucralfate. Those are topical treatments. Their efficacy, both symptomatically and endoscopically, meaning get change cellular changes that were going pathologic, they don't do much there. They do help with the symptoms. If you take Pepto-Bismol or Mylanta or sucralfate, you coat the wall of your esophagus and then you don't get quite so much contact with your acid to the wall. Move to the far right, we realize that secondary peristalsis, which is after we swallow and the lower esophageal sphincter lets the bolus in and closes, there's still a little bit of stuff in the distal esophagus. We have a secondary peristaltic wave that comes down and forces that last little bit in. If we maximize our secondary peristalsis, and we get that to squeeze several times over an hour or 2 hours, that's what the medicines on the right do. They are pro-motility agents. They make our viscous structures in our bowels move forward. The problem is, after 10-year studies, we found out they had a bad side effect of death. So we had to pull this off the market. Reglan's still on the market, but it's used off-label, and GI docs use that, and it's kind of at their own risk. So then we moved to the middle block there, the H2 blockers, Zantac, Tagamet, Pepsid. Those were all the rage until 1992. They work well, they reduce the amount of acid you produce. So it makes sense if you have an aggressive factor that is the culprit in having reflux symptoms. If you reduce that acid amount, you'll have symptomatic relief. Endoscopically, it took months for the endoscopic changes to revert back to normal. Then came the advent of the proton pump inhibitors, the PPIs, that's the omeprazole, the Prilosec, the Prevacid, Nexium, all of those. That revolutionized GERD, revolutionized gastritis, revolutionized peptic ulcer disease, which we'll kind of get down to. But in this slide, the idea there is PPIs are by far the most symptomatic relieving as well as endoscopically resolving. So that's what this shows. Do you get endoscopic improvement? Obviously, the yellow, the PPI is the best at that. What gives you symptomatic relief of heartburn and symptoms? Obviously, the yellow. So takeaway on that slide, again, the color is yellow. Now, you don't have to do, you're not going to get a histology question on a test, I'm pretty sure. But if you will just look at this and listen for a second, this is where the rubber meets the road. That's why I throw it in there. And every year Dan says, you don't need to go into that. And I say, you do if you want to know it, not memorize it, know it. So this is pretty simple. That is stratified squamous epithelium. That is distal esophagus. That is your cervix. That is the palm of your hand. That is stratified squamous epithelium. That's normal. Notice that the cells are flat. They've got one nucleus per cell. You have the papillae at the bottom, and if I had a pointer, I'd show you that vessel in the bottom right-hand corner. Blood cells are within that vessel and nowhere else. Everything looks organized there. And in medicine, something you guys are going to pick up on, in addition to the balances of everything, are the irritation theory. Anything that irritates the tissues in our body, whether it is our colon wall, whether it's our skin with sun rays, whether it's our esophagus with drinking alcohol or smoking, whether it is anything. Irritation causes cellular turnover. Hypercellular turnover is mitosis, and a missed mitosis is a cancer. So if you look at tissues that are forced into turnover, they're forced into it by an irritation, that's the irritation theory, they have a higher rate of cancer. So that's where we're going with this. So you have your distal esophagus. You have acid that's washing back up on that distal esophagus because our lower esophageal sphincter is weak. You're going to irritate that. So what happens here? So you get cellular change. Notice those flat cells are now turning into boxes. The nuclei are getting a little bit bigger, and the papillae on the bottom are getting taller. So that is the skin or the stratified squamous epithelium saying, wow, this is bothering me. I'm going to thicken and try to protect myself. That is called squamous metaplasia, which is just a cellular change of squamous cells. If we continue the irritation, we don't treat this with a PPI or an H2 blocker. It continues on to change. Now the key here is notice now that these are columnar cells. These are big long rectangles. The nuclei are still 1 per cell. 1 per cell, they're getting fatter, the chromatin's getting more dense, but the cells are getting much longer, so they're trying to thicken the actual outer layer of the skin. That would be a callus on your palm. That's what a callus looks like. That would be an ascus pap smear. When the cervix is tired of being irritated by HPV chronically, that is what happens. So if you get a pap smear back that says ascus, atypical squamous cells, Bunn-Determined significance, that's what they're looking at. It's not a cancer. That's not a cancer yet, but they say you better change it. You better stop the irritation because the next step is this. Totally random, okay? Now I'm going to go back and tell you that that's called Barrett's esophagus because we're talking about distal esophagus. That is called Barrett's esophagus. You'll see that again. You'll hear about it again. You will see it in clinical practice. That is a precancerous stage. You must stop this here. If you don't, A, your patient is going to get esophageal cancer, which is that, and B, you're going to get sued. So here, notice the random distribution of cells. There are no papillae anymore. Notice the blood cells all the way up to the surface. You've got red blood cells out of that vessel. You've got cells in that vessel. You have big crypts. You have little abscesses. Anyway, that is esophageal cancer, and you don't want to let that get there. 5-year survivability is less than 10%. So that goes to the neoplasm part of this. So chronic irritation theory, the distal esophagus causes cancer. And this slide kind of moves into that. Predilection is male over female. We don't know why. There are two types, adenocarcinoma and the squamous cell cancer. Remember, adenocarcinoma has to do with cells that produce something. Squamous cell carcinoma are the regular squamous cells turning into cancer. Adenocarcinoma is usually connected with alcohol and smoking, know that. Barrett's esophagus, notice the yellow written up there. Barrett's esophagus is associated with the adenocarcinoma of the esophagus. Those two things are linked commonly in test questions and board questions. On the bottom, squamous cell carcinoma, smoking. That's true that smoking and alcohol raise the rates of both of them. But if you directly want to look at something that causes squamous cell carcinoma in the lungs, the esophagus, and the stomach, smoking. Then there's achalasia, which we talked about earlier, alcohol consumption, obviously. Clinical manifestations, you get dysphagia, solids first, then liquids. These people say, gosh, I used to be able to swallow a piece of chicken, then I had to puree it, and then I could swallow liquids, now I can't swallow liquids. Clearly they have an obstruction. They'll get weight loss night sweats. When they get weight loss night sweats and have a dysphagia like that, you gotta work, you gotta take a look. Predisposing conditions, again, we're looking for associations here for squamous cell carcinoma. Notice those things on the right. You may have heard of some of those achalasia we just talked about. Again, you have acid staying in the body of the esophagus. It stays there, it refluxes up, your food stays there. Chronic irritation, celiac disease, chronic irritation even though it's allergically mediated. Lye strictures, some people who drink lye soap get lye strictures. Head cancer is obviously deal with this, but tylosis also. All of those things are just chronic irritants. The most important part of the slide though, Barrett's esophagus with adenocarcinoma on the bottom. So circle those. Risk factors. Pneumonic is cancers, cigarette smoking, obviously. Alcoholism, we talked about. Nutritional deficiencies. It's vitamins A, E, and zinc deficiencies have a slight predilection to esophageal cancer, also stomach cancers. Carcinogens, that's nitrosamines in uncured meats being smoked or barbecued meats. Endemic microorganisms, HPV, that's the main one they're talking about there. Regional practices in the Far East, they have a practice of drinking near boiling water and tea every day. And they have a 3.5 higher chance of getting esophageal and stomach cancer than we do. Soil salinity, the more basic your soil is, for some reason there's a slightly higher risk of esophageal cancer. But you don't have to memorize those things. Just know irritation causes cancers. Barrett's esophagus is associated with adenocarcinoma. So there's a picture of an esophageal cancer. Now, another topic, strictures. These are mechanical strictures. They are just what they sound like. They are blockages. They include webs, they include rings, they include diverticuli, but anything that stops mechanically the flow of your bolus going down the esophagus is a stricture. Disorders, you can have cervical esophageal webs. Irritation usually causes those. It's kind of like having post-surgical adhesions in your stomach. Commonly found in females, it's associated with iron deficiency. Major complaints, intermittent solid food dysphagia, but it's early, it's high in the esophagus. I swallowed it, it's stuck way up here at the top. Major complaint, obviously, is pain and dysphagia. Cineasography, whatever that is, that's EGD. Just take a scope and look down there and you'll see the web, and it looks like this. So that person had some big irritant in their past. They scarred across there. A lot of times, they will report on EGD that they ran through a web on the way in. So that actually is curative. So they notice that. Lower esophageal rings, those are also from chronic irritation, chronic reflux. Those are areas of scar. Remember that your esophagus is distensible because your bolus commonly is larger than the lumen of your esophagus, so it has to be distensible to let this go by. And if you have a scarred area of your esophagus, scar doesn't stretch. So that is called a Schatzki's ring, and it happens commonly in people with chronic reflux. What do you do about it? You go down there and dilate it. How do you tell? You give them a barium swallow and it looks like an hourglass in one spot. You don't really need to do a barium swallow. You can tell by the history. You can tell by what they're telling you. I always lock up right there. And so they go down with the EGD scope and stretch that open. Some people need that every 2 years, 3 years, 5 years, 10 years. The key is you got to ask, why in the world did that develop? You must have reflux. I need to treat the reflux. If you just go dilate the ring, you haven't done anything. Go fix the problem. Okay, diverticulum. I shouldn't say diverticuli, but Zinker's diverticulum. This is a commonly pops up on your boards as an answer, usually not the right answer, but an answer. So if you know what it is and you see it figuratively, you'll know what this is. It is a pulsion diverticulum. It is an outpouching of the posterior esophageal wall, most commonly through this little area called Killian's dehiscence, right there at the cricopharyngeal membrane. You can acquire it, you can be born with it. It looks like a little finger sticking out of the back, and it's a blind-ended pouch. You swallow food, and it gets scraped off into there. One of the signs and symptoms is people say, you know what, out of nowhere, I coughed up what I had for breakfast this morning. I've already had 2 meals since then, but I had a digested breakfast, and I coughed that up, that was odd. That's what hides in a Zenker's diverticulum. There's a picture of it, and of course the bottom little picture that didn't come up on there really shows it sticking out. But it pokes out through that little membrane. That's the acquired type that you can be born with. Easily fixed surgically, and they go in and tie it off. That's kind of a lateral look at what a Zenker's diverticulum is. But that, again, that shows up commonly as a, you know, which is the right answer. It's one of the 4 that are not correct. Now you'll understand what a diverticulum is. People can get food stuck in there at the angle, and it causes a pure dysphagia, it causes a block. So if a large piece of chicken gets hung in that thing sideways, you can't pass anything by it. Okay, now esophageal varices. This is a topic that unfortunately you'll see commonly. If you're in general practice, if you're in GI, you will see this commonly. You won't see it in pediatrics. But the idea is you have to understand what the portal venous system is. And the portal venous system, you saw in your cadavers, that huge portal vein that runs back up in the liver. You realize that when you eat, all of your food runs through your bowel. You have an incredible amount of arterial and venous, I'll say supply, that's not a good term for it, but it covers the bowel. Everything you eat is absorbed and is taken back through that portal venous system into the liver to decide what do we got to detoxify, what do we have to get rid of, what do we have to acetylate, I mean, all these things the liver does, and then it passes on to the body. If your liver doesn't work, it's a filter, among other things. If your filter is jammed, then obviously there's back pressure in that portal venous system. Well, if I have portal veins all over my esophagus, all over my stomach, all over my small bowel, all over my colon, then I'm going to have dilation of those portal veins. Does that make sense? Okay, so you're kinking your garden hose. And that is what people with cirrhosis have. So when you find people that say, my gosh, you know, I've always had bad hemorrhoids, that's the rectal plexus. I've had terrible vomiting of blood all my life. I've had these big veins in my belly button. Those people, you know, have portal hypertension. That's back pressure, dilated venous system. So in esophageal varices, inside the wall of the esophagus, those tiny little microscopic veins get huge. And just like a hemorrhoid, they pooch out into the lumen of whatever it's on. Looks like the bleb on the side of a tire. Well, if you have a vein under high pressure, and veins don't like high pressure, if you have a vein under high pressure sticking out of the lumen of the esophagus, obviously you swallow something just a little bit too stiff, dry bread, toast, a baguette, you shave the top of that off. These people, they either bleed a little or they bleed a lot. And esophageal varices is a common cause of death, a final event for cirrhotics. People with cirrhosis for any reason, whether it's alcoholism or primary biliary cirrhosis or whatever, they get portal hypertension, they get huge esophageal varices, and if you spend all your time worried about their liver function tests, which remember, treat the patient, don't treat the labs, but if you worry about just their liver function tests and you don't consider these people may have big varices and tell them, you better start sticking to mechanical soft foods, we need to do yearly EGDs and take a look at this, then you may think they're doing fine, and you get a death certificate on your desk. Diagnosis, obviously, endoscopy. I have a picture coming up in a second. So endoscopic therapy, you can go in, you have to be very careful. GI doctors are scared to death of cirrhotics because they have to go in very slowly. The scope itself can kick off the bleeding and you can't stop it in many people. You can ligate some of these varices. They're big enough, they're like a knuckle turned back on itself sticking out in the esophagus. You can put a band around some of them. Smaller ones, these guys will do injection with epinephrine to get them to constrict and then coagulate them with a hot wand. But some of these things, once they start bleeding, they can't do anything. They can't put pressure in the esophagus because it just moves around the mediastinum. So it's pretty nerve-wracking. There's a picture of one varix, that is a 3-banded esophageal varice right there. That's one single tube that's come out and gone down. They had to put 3 bands to try and stop it. Now, that can still bleed. That's going to get bigger. Over time, those bands will move further away from the lumen, and they can still shave that off. But just understand, esophageal varices are bleeding risk, not much pain. These are painless. These people all of a sudden get pale, they'll pass out, they'll get tachycardic, the wife will say for no reason. He felt funny, and he dropped to the ground and started bleeding out his mouth. But they are a real event. As cirrhosis incidence climbs, these are going to be a problem. Okay, moving on. Now we're moving into the stomach. Gastritis and PUD, this is another one of those balance things. Think of gastritis and PUD like an etiology. Gastritis is a pre-PUD or peptic ulcer disease. You want to treat the gastritis to avoid the conversion to a full ulcer. That makes sense. That's just an anatomical slide of what the stomach looks like and all of its different layers. Okay, so here's where the rubber meets the road here. It's all about the balance between aggressive factors and defensive factors. We're talking about the stomach now. The wall of the stomach has obviously multiple layers in it. And we have a slide coming up that will go over that, but it has its mucosa, it has its submucosa, it has its muscularis propria, and it has its serosa. But the idea is you need defensive factors covering that luminal wall, that serosal area, to protect it. We have our aggressive factors being pepsins, our hydrochloric acid, bile from bile acid reflux, all of these things. And if you have too many of your aggressive factors, or you don't have enough of your defensive factors, obviously you're going to erode through your mucosa, then you'll erode into the wall, and you have problems. Another representation of this, so on the left, your protective factors. In that mucosal layer, and I'm beating this horse to death because you all will see this on tests, you'll see it on boards, you'll see it in practice. But in that mucoid layer, you have bicarbonate. Obviously that's a base, so it neutralizes your acid. Good blood flow in the wall makes you or allows you to make your mucus and your bicarbonate. The growth factors supplied to the wall give you good cellular turnover, cell renewal, that's the key. And then you need prostaglandin. Prostaglandin is the key. Prostaglandins, they help to produce good growth factors and cellular turnover, and they help angiogenesis, make good arterial supply. So you have to have mucus, you have to have bicarbonate, and definitely prostaglandins. On the other side, we have our stomach acids, pepsins. Smoking causes problems, alcohol causes problems. Bile acid actually is the most aggressive thing in the stomach. People think it's hydrochloric acid. It's bile acid from bile acid reflux. That is really an aggressive force. Then we talk about ischemia, and I just talked about you have to have good blood supply to be able to have good cellular turnover. If you have ischemia, you put somebody in the unit with hypotension, they've had a big bleed, you have to protect their stomach. Because you may save them over their hypotensive event from their MI, but they'll bleed out through their stomach or they'll have an ulcer and perforate, and now a patient with a recent MI you're having to operate on for an ulcer, they're not going to survive it. So just know ischemia, think about their stomach as well. Non-steroidal anti-inflammatories, that's a catch. Aspirins, Advil, Motrins, Aleve, those are not aggressive. They're minimal acids. Their pHs in the 5.5 to 6 range. They do not erode into your stomach wall. People use that term, that eats a hole in your stomach. That is not it. They inhibit your protective production, and so they allow the aggressive factors to get in there. And I'll show you slides of that. So just know that non-steroidals and aspirin, through different mechanisms, inhibit your protection. That is how they tip the balance away from protection. So this just shows that mucoid layer. This slide's not terribly important now. This is that slide we talked about. You want to protect that mucosa, the submucosa, and muscularis propria. Muscularis propria has the vessels that feed into the submucosa that really give you the arterial supply for cellular turnover, and that allows you to have that protective mucoid layer overlying the mucosa. All right, so prostaglandin, why is it important? It's incredibly important. Again, stimulates a glycoprotein, or the mucinous part of that goo. It helps you make bicarbonate. It stimulates the phospholipid secretions by the cells. It enhances oxygen flow, so good blood flow. It increases epithelial cell migration, called restitution. Another name for it is cellular turnover. All those things we talked about on the protective side are triggered, are driven, are helped along by prostaglandins. So you don't want to inhibit prostaglandins if you can help it. we move into non-steroidal anti-inflammatories. What do? They inhibit prostaglandins. Remember that body-wide we have a list of prostaglandins. We have the E's, we have the A's, we have the I's, E2, A2, I2, all those. They each mediate some function within the body, but they all mediate inflammation. Some mediate pain, some mediate fever. And so when we have fever, we've twisted our ankle, it's swollen, our ankle hurts, we take Advil or Motrin. And it gets rid of our pain, it helps with our swelling. It does knock down some of those things. But you don't get to pick all the prostaglandins you're inhibiting. So in the stomach, you then remove your protective forces, your aggressive forces then take over, and you get the systemic or the gastric effects of the non-steroidals. And notice the yellow there at the bottom, loss of protection. These things pop up again. So here's an electron micrograph of a person prior to aspirin and after aspirin. Notice the nice cellular structure, they're protected on the left. On the right, you've allowed the aggressive factors to erode or degrade the superficial cellular structure there. All right, something else that's obviously on the aggressive side, but also is on the protective side, H. pylori. This is one of those emerging topics. It's almost not emerging anymore because it's been around for 5 or 6 years. But we've studied this little bacteria. It is a fastidious machine. This is a heavy thing. He's huge. But anyway, this little bacteria works both on the mucosal surface and the submucosal surface. This works to both increase your aggressive factors and decrease your protective factors. It does both. So obviously, H. pylori causes symptoms, gastritis. It causes signs, gastritis and peptic ulcer cellular changes, and it increases your risk of gastric cancer. This is kind of the magic organism. Now the problem is, I said it was fastidious, meaning it's quick to become resistant to the antibiotics we use. Use one antibiotic on it, within 3 days it's completely resistant. You switch the antibiotic, but still use a single agent, 3 days. So the studies all back in the early 2000s found out that you need 3 antibiotics to go after this. You have to knock it out. One of the ways, I'll tell you something back, that it increases your aggressive factors by directly stimulating parietal cells to produce more acid. It actually irritates the parietal cells to produce more acid, but the idea is you produce more acid, increasing aggressive. It also cleaves, it uses urease to cleave some of your natural chemicals into ammonia. Ammonia directly inhibits prostaglandin synthesis. So we just decided that if prostaglandins aren't there, we're losing our protection. So it increases your acid, decreases your prostaglandin, but shuts off your protection. That's how it causes all these problems. Okay, and we just talked about that. Bottom line on the bottom there, gastritis leads to ulcers. If you don't treat it, gastritis leads to ulcers. Okay, so how do we diagnose H. pylori? There's lots of ways. You can culture it, you can do a biopsy, you can do the rapid urease test, which is a popular test. Not all labs do it. Serologic is a very sensitive, very specific test looking for the antibodies against H. pylori. It's a great test, but it's really expensive. Urea breath test is about the easiest way to do it. We now have stool antigen tests as well. Bottom line is, there's a plethora of ways to diagnose this. Do it. H. pylori is detected in 90 to 100% of duodenal ulcer patients. We didn't know this in 1990. We just knew that these ulcers were getting common, but they were running in families. You find out that H. pylori is handed person to person, or can be handed person to person. Gastric ulcers, 70%. Gastric cancer from the chronic irritation, again, like we talked about, 79%. Dyspepsia, obviously, that's symptomatic. And asymptomatic people, they did random swabs and random biopsies on, I can't remember the end in the study, but on a large number of patients. Found out that 20 to 45% of the people in that study had H. pylori, had symptoms, but never really did anything about it. They were eating Tums, taking Mylanta, whatever. So it's everywhere, it's the bottom line. So what are we going to do to knock out H. pylori to help lower the risk of gastritis, lower the risk of gastric cancer and reflux as well? On the top, bismuth compounds. H. pylori cannot divide in a bismuth-rich environment. So the Prev pack and some of these triple packs include the antibiotics we'll talk about in a second, as well as bismuth. Take Pepto-Bismol 2 times a day, and it helps to inhibit the bacteria. Next, the mainstay is antibiotics. You can't do it with one antibiotic. There are 4 that are common: clarithromycin, Flagyl, amoxicillin, and tetracycline. You need to pick 3 of those. And different pharmaceutical companies have jumped on triple packs, and they make their own. And they're very expensive. A typical course for 14 days of 3 antibiotics is almost $500. And so you tell people, you've got this little bacteria, it's causing your gastritis, $500 for you to treat that. And you still have a recurrence rate. You still have about a 20% recurrence rate within 10 years. And so people think, why do I really want to do this? It's just a symptom. And then you tell them about gastric cancer, about ulcers, they say, I'll do it. But you can do this on your own. You don't have to buy or prescribe them the Prev pack or the triple pack. You can make it yourself. You can write 3 different antibiotic scripts, give them the generics, they do well. But continuing on, so we've got the bismuth, we've got the antibiotics, usually 3 of them. And then the idea is H. pylori loves a mildly acidic pH, mildly acidic, pH 5 to 6. It really thrives the more acidic you get it. And so if your pH drops, which is one reason why it's postulated that it likes to stimulate the parietal cells to make more acid to drop the pH so it can thrive, if you can raise that pH somehow, you slow it down even further. So you use proton pump inhibitors. Remember what they do. They inhibit the secretion, they indirectly inhibit the secretion of hydrochloric acid. So they turn off the parietal cells. So if I can drop my acid secretion, I elevate my pH, I dump in a bunch of bismuth, and I hit you 3 different ways with antibiotics for 14 days. It's miserable. You get cramps in your stomach, you don't want to eat, you don't have an appetite, you have diarrhea. These patients, if you tell them up front, they do well. They say, I'm on board, I will do this, this can be a diet. But they feel much better at the end. But the key here is these are fastidious organisms, and it takes a lot to beat them. And again, you have a recurrence rate, so it's not perfect. But don't blow it off. Check for H. pylori and treat it if you find it. Okay, naturally we're going to move forward to peptic ulcer disease. Chronic gastritis is pre-peptic ulcer disease. It is obviously a defect of the gastrointestinal mucosa. It extends to and through, in many cases, the lamina propria and the muscularis propria. So it is actually a hole through that perfect mucosal layer. Well, you don't want that because you're getting into where the blood vessels are. So that's where bleeding ulcers come in. And we talked about right below that mucosal layer is where vessels sit. And if you allow acid to erode into that, you're going to bleed, you're going to get ulcers. The biggest risk of this is not bleeding, it's perforation. Bleeding is bad, it's slow, it takes time to cause effect here, but if you perforate, now you have free air, and that's not good. Most ulcers occur when a normal mechanism is disrupted by a superimposed process. And that's, again, that balance. The rest of that talks about you either have to change the aggressive force or change the defensive force, and then you get your ulcer production. There's an ulcer. That's actually a tiny little ulcer, but that's an ulcer. Notice it's a volcano. It's right through that mucosal layer. Many are less than 1 to 2 centimeters in diameter. Bigger ones, worry about cancer. It's only a small portion of the PUD patients have the increased acid. So again, you kind of lean toward a lot of these things in life are decreasing our defensive forces, not always increased acid forces. And I'm going to talk about one episode of that you really have to know. And so the idea that acid is necessary for ulcer development, that is a known, but it doesn't have to be high acid. So then we go to Schwartz's dictum. Karl Schwartz, 100 years ago, he was a general surgeon from Croatia, and his dictums, he has a book of ideas that he wrote down. Many of those have never been disproven. And his dictum, which is no acid, no ulcer, and you can write that down, you probably won't see that again, that no acid, no ulcer means in a lot of his patients, back when they used to have chronic gastritis, the general surgeons would open you up and they would clip your vagus nerve all the way down the greater curvature of the stomach. And many things help you or make you produce gastric acid. The vagus nerve and the parasympathetics are the chronic tone to be able to do that. When I swallow, I'll produce acid. When I think I'm hungry, brain, I'll produce acid. All that's mediated by the vagal nerve. So we decided back then, he did, we'll just clip the vagal nerve, we'll cut our acid, and then all ulcers will go away. And then he noticed in a subset of his post-surgical patients, some of them had ulcers. And he thought, something's wrong here. So when they looked at it, all those people that were post-vagotomy and pyloroplasty the ulcers were cancer. And so the dictum of no acid, no ulcer means that if you find an ulcer in somebody that has no acid called achlorhydria, they have some genetic defect or they've had a vagotomy and they don't make acid, if they have an ulcer, that's a gastric cancer. And that's Schwartz's dictum. So again, playing into the idea of the acids versus protection, if you take that out of the way and you find somebody that doesn't make acid, they have an ulcer, that's a gastric cancer. So clinical features of these ulcers, you get abdominal pain, it's obvious. Unexpected weight loss. These people eat one bite of food, they're full. They stop eating, they can't eat, it hurts them to eat. They can get pre-meal pain. Again, golly, that steak looks good. My acid level goes up, burns my ulcer, I hurt. I haven't been eating yet. You can get meal pain or early pain. I ate, I got my stimulus from gastrin and the pancreas to give more acid, and I hurt. You can have post-meal pain depending on how much of your bolus is left in there, but it's usually pre and during meal pain. So they stop eating. You can have hematemesis, you can have black tarry stools, you can have frank bleeding, but if you have frank bleeding from a gastric ulcer, you're bleeding to death, because it's got to go through a lot of bowel work, but it'll turn dark. Triage-wise, obviously, it's all about volume and electrolytes. You need to get your IVs in. If these people come in hypotensive, tachycardic, and obviously they're losing blood, you need IV fluids. You got to give them IV proton pump inhibitors. Shut the acid off now until you get things figured out. You have to lavage their stomach, put an NG tube down. If you pull frank blood in the ER, you know they're bleeding gastrically. Yes?
What is the BRBP?
Oh, sorry, bright red blood per rectum. I didn't have enough space. Sorry about that. So that's bright red blood per rectum. And as you all are writing clinic notes and hospital notes, you'll be able to throw that down in a heartbeat. Anything that shortens your soap note. But anyway, you want to get early endoscopic visualization of the stomach and decide whether this is a varices, whether this is a Mallory-Weiss tear, whether this is a Boerhaave tear, whether this is a bleeding ulcer, and then you decide, is this cancer or not? Got to transfuse them, obviously that's whole blood there, red blood cells and platelets. Okay, clinical features, abdominal pain in almost all the patients. 20% complicated ulcers, commonly by NSAIDs. Those other numbers are just things for you to learn, not know. It just kind of brings it all together. Okay, so association with ulcer disease. Again, smoking. Man, it seems that smoking causes everything in medicine. And it does. I don't know if any of your smokers, it's not my business, but you'll see it on tests, you'll see it on boards. They're big on wellness on boards. If smoking is an option and there's some bad outcome, it's going to be one of the answers, I promise you. The whole idea, again, is the irritation factor. Zollinger-Ellison syndrome, kind of a neat thing. It used to be only one of those questions that was not the right answer on boards, but then this popped up as a question, which I think is kind of neat. It is rare, quote unquote, but I have seen it. I've also defended a family practice physician who unfairly got nabbed by a coworker for giving her a Prilosec at work, and later on down the line, years later, it turned out she had Zollinger-Ellison syndrome, and they went back and said, you gave me a Prilosec, you should have worked me up, friend, that's your fault. So be careful when you're handing coworkers samples, because you are now establishing a practitioner-patient relationship, and you are responsible for their entire medical care from that point forward, according to lawyers. So just caveat. But anyway, Zollinger-Ellison syndrome, an interesting syndrome of increased aggressive factors. The idea being, you don't have to memorize that it's associated with ME and 2 and all those things, but it is a triad of things here. The first thing is the bottom of there, non-beta islet tumor of the pancreas. And remember, the pancreas has endocrine function. That's your islet cell, that's your beta cells producing insulin, your alpha cells producing glucagon. That works with blood sugar. Then you have your exocrine pancreas. That is where you get your gastrins and your pepsins and all your enzymatic, or your enzymes for your meals. So you have endocrine and exocrine. This is part of the exocrine pancreas, and it is specifically gastrin cells. You can have a benign, but it is commonly not benign, overgrowth or an adenoma of your gastrin-producing cells. Thus, it is called a gastrinoma. And what does gastrin do? But it stimulates acid production in the stomach. So if you have an overgrowth of your gastrin-producing cells, and it is pumping out gastrin independent of your thermostat. Now remember, all these things in the body, especially hormones, are driven by a thermostat. Something senses the temperature in the room. If the temperature's below my set point, I raise the temperature. If it's above my set point, another thing comes along, lowers the temperature, and that's all that balance, another form of balance.